Hi everyone, this is Ophthal Made Easy. Today's topic for discussion is double elevator palsy. As I posted before in my shorts, this is a case of a young female of 7-year-old having difficulty in elevating in her right eye. You can see over here, in the right eye, she has a difficulty to elevate, and the two muscles which you can think of getting affected being superior rectus and inferior rectus and inferior oblique muscles. And here the two rectus and one oblique, the superior rectus can go for palsy and inferior rectus can go for fibrosis or inferior oblique palsy. These are the two elevators of your eye, and this is the one which is a depressor of your eye. Most of the time in MED is associated with your ptosis, which is your pseudotosis more than the true ptosis. Coming to the etiology, it could be congenital disease or it can be an acquired condition. As I said, the muscles, it can be because of the primary superior rectus paralysis or inferior rectus restriction or inferior oblique palsy as well, or it can be a supranuclear defect, or it could be secondary to an acquired condition like any cerebrovascular accidents or any midbrain tumors or any granulomatous diseases. Mainly in this, there are three types of MEDs: type 1, type 2 and type 3. Coming to the type 1, here it is mainly because of inferior rectus restriction. Imagine this is a globe and there are two recti muscle. One is the inferior rectus and this is the superior rectus. Whenever there is a fibrosis of this muscle, whenever I want to elevate, this will hold back the globe. So, the eye can initiate the movement, but there will be a sudden snap above which I will not be able to move. So, the Bell's phenomena here will be poor, and they have a limited upward circuit movements. Second type of palsy here is superior rectus palsy. In superior rectus palsy, the muscle itself has paralyzed. So, it's unable to initiate the movement. So, the Bell's phenomena is completely negative. Type 3 is supranuclear palsy. It's from the above. Here the Bell's phenomena will be present. The eyeball you can elevate till the midline. Above this the movement will be restricted. Now how do you differentiate all three types of monocular elevation deficiency? Coming to monocular elevation deficiency, whenever there is an MED, you can do FDT. It is called as force duction test. Force duction test. Here, if this is the globe, these are the two recti muscles. What you have to do is hold at the medial and the lateral aspect of the conjunctiva at 3 o'clock and 9 o'clock position and try to move it up and down. Whenever you are moving up and down, you can see there will be a difficulty in moving the globe up because of inferior rectus restriction. That is FDT positive. Where it will be positive? It will be positive whenever there is a inferior rectus fibrosis. That is FDT positive whenever there is an inferior rectus fibrosis. Yes. But whenever it is because of superior rectus palsy, the eye can easily move up and down. But there is an MED, that is because of superior rectus palsy, and even in supranuclear palsy, FDT will be negative. So coming to FDT positive condition, that is inferior rectus fibrosis. How do you manage it later? You have to see how much is the amount of restriction or how much is the amount of squint, hypotropia which it has caused. If it is within 10 PD, you have to do a inferior rectus recession surgery. How much? Around 5 to 8 mm of recession is required. If the hypotrophia is less than 25 PD but more than 10 PD, you have to augment the inferior rectus recession with a modified Knapp's procedure. Whenever it is between 25 to 35 PD, again you have to do a inferior rectus recession with Knapp's procedure. Now coming to what is Knapp's procedure. This is called the Knapp's procedure. Here, this because the superior rectus is paralyzed, it is weak now. Now you want to give an extra energy from the surrounding tissue. That will be your medial rectus and lateral rectus. Whatever the energy these muscles have, you are transferring those energy to superior rectus. If you are transferring whole of the muscle energy directly to the superior rectus, then it is called as Knapp's procedure. If you are splitting the muscle into two halves and sending the upper 1/3 of the muscle to the superior rectus, then it is called as modified Knapp's procedure. Knapp's procedure. This is for inferior rectus fibrosis of large angle hypotrophia. Whenever the FDT is negative, as I have mentioned, it can be because of the superior rectus palsy or because of the supranuclear palsy. If it is because of superior rectus palsy, then also they can have a hypotrophia. Again, measure the degree. It is less than 10 PD, less than 25 PD, 25 to 35 PD. If it is less than 10 PD, you have to go for IR recession with modified Knapp's. Positive FGT, superior rectus resection can be done. If it is previous inferior recession is done, you have to go for modified Knapp's procedure. More than 35 PD, IR recession with augmented Knapp's procedure has to be done. And this is how the MED has to be managed.